Hello, everybody. It's a great pleasure to be present in front of you today. It's unfortunate that due to COVID-related issues, I cannot make it in person to see you and see your beautiful city today. But still a great pleasure to present the updates of the WHO classification of breast cancer to you today. Uh, the image in this slide is our pathology lab, which for multiple reasons ended up being a standalone building, and we get to see live in this beautiful building. So let's start at the basic about classification. What is the role of classifications? And the basic idea of classification is to group lesions of similar nature for better characterization, prognostication, and management. And those are the primary goals of any classification. And along the lines, somewhere we need to understand the biology, we need to understand the critical targets that are present within the tumor, and then ultimately whether the patient should be treated or not treated, because tumors that have very good prognosis may not need any additional therapy, while those that are aggressive need a very aggressive therapy. So with that kind of background, let's look at classifications in general. So in cancer classification and breast cancer classification in specific, we have three major types of classification. The first, of course, is the TNM, that is tumor, node, and metastasis classification, on which the American Joint Commission on Cancer, or the AJCC classification, is based on. And this is purely prognostic in nature. That is, it tells you a lot about the nature of the disease, whether it's aggressive or not aggressive. And this classification is used to define stages 1 to 4. Then we have the biomarker-based classification, which divides tumors based on the expression of three basic molecules, the ER, HER2, and Ki67. And based on that, we define patients as having ER positive tumors, HER2 positive tumors, or triple negative tumors. And then again, Ki67 is used to determine proliferation rate, which may directly correlate with response to chemotherapy. And then lastly, we have the histology-based classification, which includes grading of tumors from grade 1 to 3, the Nottingham grading system, which is the modified Scarf-Richardson grading system, which identifies as grade 1 tumors has the best prognostic and the grade 3 tumors as having the poor prognosis. More and more, we have moved into a joint classification system that involves both the TNM and biomarker systems, and the role of histology-based systems is increasingly being questioned. So, why undertake histologic classification? Well, there are certain histologic types, such as tubular carcinoma, colloid carcinoma, that are extremely good prognosis. Some grade 1 cancers definitely have better prognosis and may not, those patients may avoid getting treated with chemotherapy, particularly if the tumors are small. While grade 3 tumors, one would have to treat them aggressively. There's also a predictive component to it. That is, tubular carcinomas, colloid carcinomas may not need chemotherapy. Same thing is true with adenoid cystic carcinomas of the breast. And then there are other cancers where histology is of very limited value. And this goes into terms of invasive ductal carcinomas and lobular carcinomas for that matter, and then special histologic types of variety of nature. So what is the role of WHO classification? WHO classification essentially has been devised for epidemiological purposes. That is, patients with tumors from different parts of the world should be categorized along similar lines. And that has really been the sole purpose of the WHO classification. However, over time, it has morphed into an academic power assessment system and become much more of an intellectual exercise of differentiating tumors into a variety of different subtypes and feeling good about classifying things into subtypes and subtypes as an academic exercise rather than something that has been useful for patient management. The fifth edition of the WHO has somewhat of a reality check to some degree. That is, it basically says that histology has its role but may not be all and end all of everything that needs to be done. It removes some unnecessary entities by consolidation into a broader category of invasive carcinoma. But on the other hand, it also recognizes some new, very rare entities such as mucinous cystadenocarcinomas and columnar cell lesions with reverse polarity. And we'll talk about those in the latter half of the talk. So the major changes in the WHO classification, and the most important in my mind, is the recognition of the importance of molecular classification. And this molecular classification is essentially based on traditional ISC classes, that is, ER positive, HER2 negative, ER positive, HER2 positive, ER negative, HER2 positive, and HER2 negative, ER negative. Note, there's an absence of requirement of progesterone receptor in the analysis. And this is broadly reflected in the British style of practice, where progesterone receptor has been increasingly not being analyzed in the routine management of patients. In the US, we still routinely do progesterone receptor because we believe it's a good surrogate of ER activity. And there's at least some data to suggest that patients with ER positive, PR positive tumors have a better prognosis than ER positive, PR negative tumors. So as it may be, we are increasingly going to be recognizing, and the WHO has for the first time recognized the importance of molecular classification of tumors in addition to the histologic classification. The second major change that has occurred in the new WHO pertains to medullary carcinomas. Medullary carcinoma is no longer recognized as an entity. It's been a problematic and confusing lesion for a long period of time, partly because, as originally described, it was a solid tumor with circumscribed growth pattern and lots of lymphocytes. Beyond that, additional portions of definitions were added, which included the need for having syncytial cytoplasm, the need for having prominent nucleoli, the need for lack of a significant DCIS comp associated. And the problem then became is we are defining a class of tumors that has a relatively bad histologic appearance, and yet we are calling them as good prognostic tumors. The question then comes, is good as compared to what? Is it good as compared to a traditional triple negative tumor or a traditional high-grade tumor? Or is it good compared to something like a tubular carcinoma? And the answer is the former rather than the latter. That is, it might have a better prognosis as compared to a bog standard grade 3 triple negative tumor or a high grade tumor. But this confusion has often led to some patients not getting chemotherapy. And that's been a major concern that has been voiced for a number of years now. And at last, the WHO has taken the major step of removing it from the as a separate category from the WHO classification. So where do we put these tumors? Well, increasingly, we have recognized that there is a major role that the tumor microenvironment plays in determining the prognosis and outcomes of cancer patients. Here's a very rough guide of what we are talking about. So the current focus in terms of cancer prognosis focuses predominantly on the tumor cell morphology and excludes the tumor-infiltrating lymphocytes, the angiogenesis, the tumor-associated fibroblasts, and a number of other cells that are present in the tumor microenvironment. Now we are talking about more and more about the role of tumor microenvironment in the development and progression of disease, particularly with the recognition of breast cancer and several other cancers as immune-associated diseases. This has become particularly clear. So on the right-hand side of the slide, we have a figure developed from Hanahan and Cousin's paper in Cancer Cell in 2012, talking about the variety of roles that the tumor microenvironment plays in causing the growth and progression of cancer. As you can see by the various symbols, we are talking about immune cells, we are talking about endothelial cells, as well as dendritic cells and cancer-associated fibroblasts. All of these contribute to a variety of functions that are collectively known as hallmarks of cancer. So the question basically is, what is the evidence there exists to figure out that tumor-infiltrating lymphocytes are important? And this is basically the first paper that looked at it in some detail. This was a paper that came out in 2013, where they looked at the big 0 to 98 clinical trial and basically studied the presence or absence of lymphocytes in a quantitative manner in patients with triple negative and HER2 positive breast cancer. As you can see in the survival plot, that patients with lymphocytes, particularly with lymphocyte predominant pattern defined as greater than 50, have a good prognosis as opposed to those that have fewer lymphocytes. So this paper was probably the seeds, sowed the seeds for the immunological recognition of breast cancer. When this paper came out, there was a considerable amount of debate in our group as to whether this was truly important or was this anecdotal finding that would not be seen in other study sets. So we conducted a study of combined cases of 1199 and 2197. All patients were triple negative as analyzed by IHC. And we studied full sections. Two breast pathologists looked at it, myself and Dr. Di Maria from New York. And we basically analyzed for the expression of tumor, for the presence of tumor infiltrating lymphocytes, both in the stroma and in the epithelial component. We also had a subclassification, as was used in the Loy paper, of 50% as a cutoff. What we basically observed was that intraepithelial lymphocytes were associated with prognosis. However, there were very few cases of intraepithelial lymphocytic infiltration, and therefore the impact of that particular marker was restricted to a handful of cases. But what was more significant was the amount of lymphocytes that were present within the stroma. And that has become the standard of what is being analyzed. So looking at these two basic studies that form the basis of recognition of tumor-infiltrating lymphocytes as a valuable prognostic marker in triple-negative breast cancer. Here are the two studies compared side by side. In the Loy study, there were 256 patients with an 8-year follow-up. In my study, there were 481 patients with a 10.6-year follow-up. The methods were somewhat similar, where we analyzed things. But what is most important is, again, you'll see that the p-values for intraepithelial TILs with 10% increase is kind of reaching borderline significance. But if you look at the hazard ratios for the stromal TILs, you can see the hazard ratios were very similar in the study of Loy et al. And in our study, Adams et al. And with this similarity in hazard ratios, this was constituted level 1 evidence to suggest the importance of lymphocytic infiltrate in triple-negative breast cancer. So in the original studies, there was essentially no agreement between the methods employed. And we thought it was important for standardization of methods. And therefore, we did this work together with Robert Salgado, who was the pathologist on the Loy paper, and invited a number of people who were associated or interested in working on the TILs to join us. And this paper has become the standard for TILs analysis and based on the recommendations of our international TILs working group. So what do you mean by TILs analysis? So the first step for the evaluation of tumor-infiltrating lymphocytes is define the border of the tumor. Once you have defined the border of the tumor, then you start looking at immune infiltrates within the borders, excluding areas adjacent to normal tissues or TCRs. The next step is to scan the slide with a focus of stromal TILs. And basically what you do here is exclude the areas of epithelialness and just concentrate on the stromal areas as shown in the figure on the right. The black inked area is all the area that's counted. Of course, we do not include areas of necrosis, and that contains granulocytes of variety of nature, including neutrophils and eosinophils, but you focus only on the viable areas that are there. And then using that approach, you basically look at the compartment, that is the stromal compartment, and identify the density of lymphocytes that are present in that compartment. The lymphocytes as defined here consist of anything that is mononucleated. That is, it includes lymphocytes, plasma cells, macrophages, myeloid-derived stem cells, you name it. Anything that can be there and looks cellular and lymphocyte-like or immune-like is included in that analysis. And therefore, you have a whole range of values ranging from 0, that means there are practically no lymphocytes in the stroma, to 100, in which every space within the stroma is occupied by tumor-infiltrating lymphocytes. And that range is also reflected in this figure here, where you have a graphic representation of the amount of lymphocytes that are present, as well as a histologic image. And again, this is a well-traveled image that has been published in the Salgado paper in 2013. So apart from this recognition of tumor-infiltrating lymphocytes, the WHO also recognizes a couple of new entities. This is the first of the two, which is called mucinous cyst adenocarcinoma. Now, mucinous cyst adenocarcinoma is again a very rare entity, which consists of a fibrous wall cyst, which contains intracystic mucin that resembles ovarian or pancreatobiliary mucinous cyst adenocarcinomas. Inside the cyst, there are papillary projections, as you can see here, that are lined by tall columnar cells. Now, although this entity is recognized, we do not know the lot in terms of the prognostic implications of diagnosing this entity. That is, how invasive is this? Should this patient be treated with chemotherapy? And those kind of questions are still open. However, histologically, these are characterized by columnar cells that show stratification, tufting, papillae formation, and the nuclei tend to be basally located with abundant mucin. So although we don't have a great idea about the biology of this disease, we recognize that this is a distinct pattern and needs to be studied further to understand the prognostic implications of this entity. Another new entity is tall cell with reverse polarity. Now, this is a rather difficult entity to diagnose. It's extremely rare, and it consists of overlapping features between solid papillary carcinoma, papillary DCIs, infiltrating epitheliosis, and invasive papillary carcinoma. This is characterized by circumscribed nest of epithelial cells distributed mostly in a dense fibrotic stroma, which contains a solid papillary pattern. True papillae and cystic structures may contain colloid-like material. And as shown here, the papillary structures can contain immune cells as well as foamy macrophages. The nuclear features can resemble those of tall cell variant of papillary carcinoma of the thyroid, in addition to the cells showing a reversal of polarity when you start analyzing the polarity of the cells using MUC1 or such antibodies. Here's an example of the immune staining pattern. Myoepithelial cells tend to be absent or very focal. Calponian also is very weak. And so here's an example that we have shown where you see a calponian expression around the duct of normal structures, but it's absent within the solid papillary area. Similarly, these tumors tend to be ER negative or show very weak focal ER positivity. They express both high and low molecular weight keratins and carry the mutation of IDH2 at R172 location. So those are the two new entities that have been introduced. There is some reclassification and rewording of tumors and classically seen in terms of terminology change for neuroendocrine tumors. Here, for example, you see neuroendocrine tumors are now classified, neuroendocrine neoplasms are now classified as low-grade lesions that are called neuroendocrine tumors and high-grade lesions that are called neuroendocrine carcinomas. Again, this is now consistent with the terminology used in lung cancer, where the low-grade lesions have a carcinoid-like pattern and may have associated ductal carcinoma in situ, while the high-grade lesions can resemble small cell carcinoma of the lung or large cell neuroendocrine carcinoma of the lung. And these are high-grade lesions. So basically, we are now classifying neuroendocrine neoplasms into low-grade and high-grade lesions. And here was a review article that was published by Pareha and colleagues in the Breast Journal in the recent past. And what you can see quite nicely here are the two different categories and morphological, immunohistochemical, and molecular features associated with them. So the main point here is this neuroendocrine tumors are the carcinoid-like tumors. They have grade 1 or grade 2 nuclei, while neuroendocrine carcinomas have grade 3 nuclei or resemble small cell carcinomas of the lung. Then there are things that required some additional evidence that was provided in the new WHO classification. And Microinvasive carcinoma is one such entity that required some kind of clarification. And basically, the new clarification is something that is invasive coming out of a duct is sufficient. We don't need to have invasion of non-specialized stroma. If you remember, the old classification insisted that the invasion should not only be of the specialized stroma around the duct or lobule, but also non-specialized stroma surrounding the duct. That definition is no longer required. Invasion is now defined as to be present beyond the myoepithelium and basement membrane of the in situ component. Again, no requirement for specialized or non-specialized stroma, and the invasive component should be less than 1 millimeter. And again, microinvasive carcinomas can be seen with any form of disease that is in situ, that is DCIS, lobular carcinoma, or in situ or patches disease of the liver. Additional evidence also is required for mixed type of cancers. As you might remember, we tend to classify tumors into specialized types if more than 90% of the tumor has that kind of architecture. So, for example, invasive papillary carcinomas, invasive cribriform carcinomas, or tubular carcinomas need to have more than 90% of that particular form of architecture to be classified as such. The question that arises is what happens if it is less than 90 and greater than 10%? And that's something that we need to think of, and we need to have additional evidence to figure out how do we classify these subtypes. And for real, the question is it necessary to classify these subtypes into specialized categories? The other point, of course, that comes up is when you have mixed types of tumors that consist of high grades or low grades or ductal and lobular. Now you're basically recognized that you can give a diagnosis of mixed invasive carcinoma, MST, and then say that there is also an invasive lobular component that accounts for 30%. So those kind of percentages are now permitted to be used by the WHO classification. Most importantly, they basically say that grade and biomarker status of both components should be represented, and it's recognized that they are distinct. The question comes up in terms of management is how do you go further with this? And that question remains to be answered. So for example, if you have a mixed duct and a mixed invasive carcinoma and lobular carcinoma, how should the patient be treated? Particularly if one component is ER negative, other component is ER positive. Should those patients get chemotherapy? Should those patients be managed only with endocrine therapy? All of these questions still remain to be addressed. There are some other minor things such as format changes. As you will note, the special subtypes have been all combined together under the major category of special subtypes and all listed together with some minor definitions that have been put together. Another thing you will notice is that all the benign proliferations have been pulled together. Same thing for intraductal papillary lesions. So in the older classification, epitheliosis and adenosis and those kind of things were combined, separated out from adenomatous lesions, and all of them are now included in the same category. Another form of format change is that each entity is now defined by additional subcategories. So, for example, tubular carcinoma, there are another 4 or 5 headings that have been added. If there are subtypes, if there is a predilection for location, the pathogenesis, if any known, the cytological features, and essential and desirable diagnostic criteria. So these really help refine the categorization of tumors into subtypes. So to conclude, there are a couple of major changes that have been there in the new WHO. Most important of which is the recognition of the importance of immunohistochemistry and immunohistochemistry-based classification in classifying breast cancer. Also, the role of tumor microenvironment and more particularly, the role of tumor infiltrating lymphocytes. And last but most also importantly, consolidation of tumor histologic types, because for many of these subtypes, the treatment does not change significantly. So having them considered as special types under one category makes a lot of sense. There are also some changes that need some thought. The recognition of new entities is, of course, important so that we all categorize those as distinct from the rest. And more importantly, we better understand the biology of the disease that they are associated with. Minor changes include reclassification of neuroendocrine tumors and some minor changes in definitions of tumors that have been done. So with that, I'll thank you again for the kind attention and inviting me to present at your symposium. It's been a great pleasure. I hope to see you in person in the near future. Thank you and good night. Bye-bye.